Do you see prevalence in etiology?
Yes, yes,
Yeah.
we can see.
Okay. So I think I fixed the issue on my side. So when we think about para here that I've lined up in the right anterior oblique, which is the left, the mitral valve. And it is pointing left to right, and there's no duplication, so you're right on. This allows me to determine anterior and posterior. So anterior is on the top of that band, posterior is on the bottom. On the right, I can demonstrate lateral to the right of the screen and medial. And then equally important, one has to see the full excursion in some view of the leaflets, because the device could interfere with leaflet excursion. So once you're across and you are positioning your device, you have to go to the view that allows you to see full excursion of the leaflets and full closure before you release the device, because once you release it, there's no going back. So there was a nice experience from Europe that was published by the UK and Ireland in Circulation in 2016. And when we look at the left-hand side of the screen, this is the severity of the mitral regurgitation pre-percutaneous closure. And one can see in the lavender that 61% of folks had severe MR and 34% had moderate. And following the procedure, which is the second column, one can see that about a third of folks had complete resolution of the mitral regurgitation, and about 40% were left with mild, and about a quarter were left with either moderate to severe. This correlated with an improvement in functional status. On the left, one can see that the vast majority of patients were class 3 or class 4, approximately 65%. And following the procedure, 50% of folks were class 1, and then another 40% were class 2. Only approximately 10% had class 3 or class 4 symptoms. So taking the paravalvular leak from severe to at least mild is important in an effort to improve the functional status of the patients. This translates as well into event-free survival. So for individuals who are left with moderate or severe MR, one can see a divergence of the curves beginning at approximately 3/4 of a year, so that by 3 years, the cumulative survival was only 40% as opposed to approximately 65%. So getting a good result with the paravalvular leak closure is essential in an effort to improve symptoms and survival. So can you hear the speaker?
Yes, yes.
Great. Give me one moment.
So that was a case that I did a couple of years ago. I did the paravalvular leak closure, and then Faraz did the mitral clip. And it demonstrates a unique application of combined techniques to deal with some of our elderly and frail patients as an alternative to redo surgery. That was a particularly challenging approach, but the techniques are very similar. I'm going to share an aortic case that my interventional fellow and I did just a couple of weeks ago, followed by a standard medial mitral case. And these were both fun and both went really well. The first case was that of a mechanical aortic valve, and it was a 23 millimeter St. Jude Regent mechanical aortic valve. And I think it's always important that one looks up the particular valve, understands the sewing ring, understands the height of the valve and how that transitions, because it will help you understand how to deploy the actual, in this case, it's going to be an AVP2. So this is a multi-purpose with a glide catheter. You can see the mitral valve here. You can see the aortic valve here, and you can clearly see that our catheter is outside the plane. You do not want to advance a catheter through a tilting disc valve because you may not be able to withdraw it. You'll always be able to withdraw a wire, but catheters can become entrapped. You can now see our multi-purpose guide going over the glide catheter. So we have good positioning. Here is the guide, and you can see the movement back and fro, and that's because of the transmission
across the aortic arch. This makes deploying the catheter AVP2 delivered device challenging because you have to get rid of all of that slack. And so here you're going to see my first attempts. I backed everything out. Here is the first disc. And on the right, you can see the mid-lobe and the aortic disc. You can see that the valve leaflets on the right are moving well. And the question is, did I get enough of this middle lobe across the whole? And so that's where transesophageal echocardiography and aortography are helpful. So here on the left, I'm injecting through the guide, and you can see below it that there is a hint of contrast coming all the way down into the LV. On the right, you can see the device, and with color, there is still severe AI. So I have to recapture this while not losing my ventricular position. And so here I am proceeding with recapturing the aortic disc, the mid disc, and then leaving the third disc in the LV. And I take what I've learned, and now you can see that middle lobe is much more inferior to this band. And by echocardiography, we've gone to trace aortic insufficiency. So same size device, positioned differently, can provide you either severe aortic insufficiency, an inadequate treatment, or an outstanding result. And so I've confirmed that these leaflets are moving well. There's just trace aortic insufficiency. And now I'm going to release this. The mid-lobe seems secure, so the probability of embolization is low. And you can see now leaflets are moving, device is secure. This is not interfering with the outflow. And we had no significant aortic insufficiency. On the left, severe AI. On the right, no aortic insufficiency. So this person had class 4 symptoms. I just spoke with them last week, and they are now asymptomatic. The final case that I'd like to share with you is a lady in her 70s who was hospitalized with refractory ongoing heart failure on IV diuretics with secondary moderate pulmonary hypertension. She had recently, in April, undergone operation with 3 valves treated. The 27 millimeter Medtronic Mosaic was placed in the mitral position. An Edwards resilient.
A lot of over. Besides this, as a novel, I was that we used to, also the indication for LCDN.
Sorry.
Right? So that was the system. This one is a catheter. The catheter on the table, the name is called dual probe. Dual.
Thank you, Dr. Wanapa. And Edwards Resilia was placed in the aortic, and then the tricuspid was treated with an annuloplasty ring. And so she had severe mitral, and unfortunately, it was in a medial position. And so here you can see under TEE guidance an extra sharp Brockenbrow needle. And these atrial septums are often thickened from the prior surgery. And this was quite challenging and required a lot of force to do the transseptal. We were successful. And you can see here on the left is my Agilis. You can see aortic valve at 12 o'clock. and you can see the mitral valve with the associated posts. You can see 3 circles. That's a mitral. And then you can see the ring, which is the tricuspid ring. And so we're going to, and you can see now it initially was crossing through the valve. And now you can see us crossing posterior through the actual defect. That's a glide catheter. And then over that glide catheter, I advanced the 6 French sheath. On the right, you can see at the intersection of the red and green lines, my catheter crossing medially through the defect. Just a moment. So there is the glide catheter, and I'm now trying to advance the sheath, the guide, and you can see it's kinking right there just to the left of the mitral valve. So I'm going to have to pull that back and change how I'm advancing the force. So I had to remove the force and then work with the Agilis sheath in an effort to ultimately, you're going to see it now, I got rid of that acute angle. And now I have the guide, and now it's going to cross, and it just crossed through. So then I can take the multi-purpose out. And now I have an AVP2. That is the left ventricular disc. And I'm going to slowly pull it back. I'm right where those post markers are. And now I'm going to have to guesstimate how to deploy that mid lobe, which you're going to see here in just a moment. Now I'm beginning to release the middle lobe and deploy it. And now you see the middle lobe, but it's not constrained. So that's not a good deployment. And there is severe residual MR, so I had to recapture it. This is an additional deployment, and I still have severe MR. And now I have the middle defect to atrial. So I had to recapture it again. And each time I'm learning about how to deploy that mid defect. Now you see it constrained. And that is a much better positioning. You can see that middle lobe is constrained. And you can see clearly that we have the first disc on the LV, the third disc still tethered to the cable in the left atrium, and now this oblong middle shape, which is now occupying that paravalvular leak. And TEE demonstrated reduction to trace to no mitral regurgitation. And you can see on the left, the medial color jet. And on the right, now you can see the left atrial disc and just trace mitral regurgitation. And she went from refractory heart failure in-house to being discharged the next day. She had V waves pre-procedure of 50 to 60 and post-procedure 20. And so our standard approach is that at 1 month, we'll repeat a transthoracic echo. We will obtain a CBC, with hemolysis markers because 3% of patients may develop severe hemolysis. We'll assess how they have responded clinically. Typically, if a person has atrial fibrillation, we will resume antithrombotic therapy the next day. In the absence of atrial fibrillation or another indication, we simply utilize dual antiplatelet therapy, and we recommend antibiotic prophylaxis for 6 months, and we proceed with an annual transthoracic echo. And if there appears to be a change, then it's important to repeat a transesophageal echocardiogram. So those were 3 cases that I thought would be interesting to share with you all and give you my approach to how we treat paravalvular leaks at OHSU.
Yeah, thank you. That is a brilliant skill and in advanced structural heart intervention. I guess we don't have this experience. I see Dr. Mann in among the audience. Dr. Mann, can you comment on your skill or experience on the
Hello.
paravalvular
Yeah.
leak?
Can you hear me?
Absolutely. Good morning. How are you, Dr. Mann?
I'm good. Thank you. Thanks for sharing all beautiful cases. We do have some experience with the paravalvular leak as well especially for these both mitral and aortic. We also just got the AVP3, and I have used them, and it works quite well as well. It's kind of similar to AVP2, but had kind of crescentic kind of shape, and in some defect, it's really helpful, and the disc is not less protruding into interfering with the prosthetic valve. So that's I'm not sure in the States is the AVP3 is also available or is
No,
not FDA approved. Yeah.
we don't have it, so only under investigational purposes
Oh, yeah.
can one use it. So we're primarily stuck with stacking AVP2s
AVP2.
for our larger defects. So if I'm going to put multiple devices, I switch out the Agilis for shuttle sheath and place a second wire so that we can always maintain positioning across that. Rarely I will do simultaneous deployment to 2 AVP2s, but typically I do them sequentially.
Yeah, I think that's great. Other than that, I think we share similar approach. Lately, there's a few more challenges in paravalvular leak in TAVI, like a significant EBL post-TAVI in the aortic position, and that really more challenging because the valve frame usually quite tall, in particular the evolute group, and the defect is not smooth and round or crescent. So those are very challenging as well. Yeah. So that's with my little experience with the PVL closure. Yeah.
Yeah, I've had much better success with surgically implanted valves than I have with percutaneously implanted valves.
Yeah. Yeah.
Between the frame and the skirt,
Yeah. That's tough.
it's easy. I've gotten wires through the defect. It's getting, the glide catheter and a delivery sheath into and across the defect that I frequently encounter challenges.
Yeah, and I think Dr. Siguro showed us that the deployment need to be really as perfect as possible because some of the cases we leave the residual leak, even though very small, but that usually cause very high velocity jet, and hemolysis, intravascular hemolysis is really a bad one, in particular in the mitral position. I think that's another pitfall or disclosure.
Yeah, I must admit, Dr. Mann, that my first 5 to 10, I didn't have the nuances of how to deploy that middle lobe of the AVP2. And that led to suboptimal, treatment of the paravalvular leaks. Following those cases, then I learned the subtlety and the importance of recapturing and redeploying before trying to add a second device.
Yeah. The last case I did also similar. Someone put the AVP2 in a few months earlier, quite wild, and then the patient keep coming back with hemolysis and required regular transfusion. So we went back in and crossing that residual leak. It's not that easy because the hole is pretty small, but sometimes need to put in a second device for that. So hemolysis is a big problem. I completely agree. And in bad cases, it can cause renal failure from this myoglobin toxicity to the tubules, and that can be really bad. Yeah. But anyway, thank you for sharing the case. Thank you, Dr. Damrat. We had some experience, and not a whole lot, but yeah, good to see how Dr. Siguro does the case. Thank you.
Thank you, Dr. Mann.
When I see your last presentation on transesophageal echo, that is one of the best image that I have ever seen after you put in your ATP2. Can you show us again on your last TEE, besides the mitral valve? That's beautiful.
Give me just a moment.
It is quite rare to see have good image on TEE after you close this paravalvular leak. I want everyone, the audience, to see this TEE image.
I must admit, Dr. Damras, that imaging is easier, at least for me, for mitral. Aortics are very difficult with a lot of shadowing, and it's much harder for us to characterize the aortic defects during the procedure than it is a typical mitral. So let me see if I can get this back up.
Dr. Siguro, it's Man again. Do you do CT scan pre-procedure planning in all cases, or in TE base mainly?
So I'm doing a really challenging one in July, and I am getting a CT in that one. For me, most of the information from a resolution perspective and thinking about which quadrant the defect is, I tend to process better TE imaging than CT, but I think that's because I don't do TAVR implantations anymore or mitral implants. So for us is much more adept with the CT reconstruction than I am. So I rely heavily on 2D and 3D TEE. Are you able to see my screen too?
Yes, I see your screen, but it doesn't move. It is a freeze frame.
Give me just a moment.
Yeah.
It's moving now.
On the right image, we can see
Yes.
the AVP. That's beautiful for the
So
closure
that's
of the,
pre, and there is the
yeah,
final.
that's one.
And as this endothelializes, that trace MR will disappear.
Yes. Brilliant skill.
So those were just a couple of the cases. The first one was a unique adaptation lateral to the Alfieri stitch, what I thought you all would find quite interesting. I doubt I will ever do that again in my life, but it was a fun case to position AVP2 with a lot of angst. The last two I literally just did 2 weeks ago, and tomorrow we'll do another aortic paravalvar case. So I thought those would be fun to share with you all.